Thanks for being with us today. We are here with Dr. Joanne Conroy, our new CEO and President of Dartmouth-Hitchcock. We'll get started in a couple minutes. We want to give people time to log on and get ready and settle in, and hopefully you brought your lunch today so you can eat with us as well. So just a couple of housekeeping things. If you want to submit a question to Dr. Conroy, please just type it into the comments section. We're monitoring that, so I have someone on the side here who's going to hand me questions to ask Dr. Conroy. If you're watching this on playback, please feel free to also ask questions in the comments section. Dr. Conroy is a Facebook user, so I'm sure she'd be happy to answer your questions online. And we'll be doing this again, so we can also have questions in the future. We also had a couple of questions submitted in advance, so I'll be asking those as well. So hopefully everyone has had time to get logged in. So we'll go ahead and get started. My name is Victoria McCandless, and we are here today with Dr. Joanne Conroy, who is our new CEO and President of Dartmouth-Hitchcock. She started on August 7th, so I think this is week 10 or 11?
Week 10, it's week 10.
Oh, great, great. So the first question that came in advance is, how's the job going? Do you have anything to share with us?
So it's going very well. I have to say that I've spent a lot of time not only meeting with people here at Dartmouth-Hitchcock, but really across the health system, which is much bigger than a lot of people would initially appreciate. So we have sites in Cheshire and in southwestern Vermont. We have sites in Mount Oscutney, New London, and certainly a large practice present in Concord, Nashua, Manchester. So I would say I'm on the road at least a day a week, going down to visit the sites, participating in medical staff meetings, and just listening to people.
That's right.
You know, I have been able to also meet with all the former leaders here, which has been really interesting. So Jim Varnum, who was leading really in the kind of late 80s, early 90s, Tom Calaccio, Nancy Formello. I have lunch with Harry Bird, who was one of the very early clinic leaders. And yeah, it's been great. They've all had a lot of great advice and are been actually very supportive. An interesting comment that Nancy Formello made was that when she took a role at Beth Israel in Boston, it was 1 month before the Boston Marathon bombing.
Oh, right.
And she thought of me when I was here. It was week 5 when we had our active shooter. And she made an interesting comment. She said, it will embed you as a leader in the organization much more quickly than if it hadn't happened, because you have that shared experience with all the employees. But what's interesting, I said, yes, I sense that, but what it also gave me an opportunity to see was really the leadership that a lot of the employees exhibited during that time period. So that was great. So yeah.
So far so good.
Yep.
Great. Well, we have a couple of questions that were submitted in advance that I'd like to ask you. So someone asked, I know you just started your job, but do you have a sense of what your number one priority for change is at Dartmouth-Hitchcock?
So actually I have 2.
Oh, great.
So the number one priority is we have to start thinking and acting like a system. We have heard that from all of our affiliates, which are really the sites outside of our traditional Dartmouth-Hitchcock structure. They want to act like a system. And as a system, we're going to have to start to be really clear on the things we want to be tight on, meaning what we want to do across the entire organization, and things that we can be loose on, the things that we want local autonomy and local decision making to really have priority. So the things we want to be tight on is going to be quality and safety standard practices. Really difficult to argue that we shouldn't all have the same standards. And so George Blake is actually leading that charge. Another example of something we might want to be tight on is specialty physician hiring, because they're really a high cost, high quality service that we would want to distribute across a broader network to make sure that they are professionally and personally fulfilled as they can be. That means, serving patients in multiple locations. So we need to do that together. But things that we might be loose on, maybe primary care, because it's such a local area of focus. How do you allow the individual sites to really identify and grow their primary care workforce that meets the needs of that community. That's difficult to make that decision centrally. So I think successful systems can try to figure out what to be tight on and what they need to be loose on.
Well, that makes sense since we have such a broad spectrum of geography. So the clinics in the southern part of the state, they're in an urban area, so that's very different than up here. So that makes sense.
Where it's rural.
Right.
And when I think about it, the distribution of critical access hospitals that we may not own, but they depend on us because we're their quaternary care center, but also we help them by actually providing and sometimes selling them services that they need in order to be financially viable. You know, they are a really important network for us, and they're important for their communities because they're the largest employer in their community, and they're kind of an anchor for the community. So we have a vested interest in, even if you're not necessarily part of our network, really making sure that broad network stays very stable.
That's great. Now you mentioned you have another priority.
I do, engagement. Engagement is one of our most important initiatives over the next year.
Are you talking about employee engagement, or what do you mean by that?
Employee engagement. Every year, companies, sometimes every 2 years, do an assessment on how engaged their employees are. And people may say, well, isn't that just employee satisfaction? That's different. Employee engagement is how employees feel connected to the organization. An example is the difference between renting a car and buying a car. How many times have you rented a car where you washed it before you returned it? No, you don't do that. But when you own a car, you wash it a lot more and you worry about it a lot more. We want people to feel like they own a component of the organization. It's also really important for our strategy. You can't really lead a strategy throughout the organization without having the employees engaged. It's like leading a parade and you turn around and there's nobody behind you.
Right.
And so it's not only important for creating a great environment to work, really have employees feel vested and invested in the organization, but also it's the number one way you're going to drive a strategy through the organization.
And that makes a difference for patients as well, right?
It does. Well, engaged employees are, it's like the happiness with home ownership. It's if they feel really a part of the organization, they're not only happy to work there, but they're really committed to making sure that everybody's experience here of another colleague, employee, and or a patient is something that they would be proud of.
Sure.
So that's why it's so important.
Yeah, that's great. Well, I'm going to pause a second, and if anyone has just joined us online, please feel free to put some comments, ask your questions for Dr. Conroy in the comments section. We are monitoring those, so I'm happy to ask those questions. And if you're watching this on playback, please feel free to ask those questions as well, because we'll be monitoring those and we'll make sure your questions get answered. So I have another question that was submitted in advance. Again, Dr. Conroy, I know you're brand new here, but we're looking at the future of Dartmouth-Hitchcock. What is your sense of how things should be, especially in a challenging environment like the southern part of the state?
So one of our most important decisions we have over the next few months is really identifying partners in the state. We are not planning on building a hospital, but we provide a lot of outpatient services that need a hospital partner. So we will be developing and forging a relationship with a hospital in the southern region. I think it is critical for us to have an organization that's aligned with us on how and where we deliver care. We take care of a significant number of the citizens of Manchester, a little fewer in Concord, and probably a similar number in Nashua. Close to 20 to 25 people who live in that urban area we touch as our patients. And we need a hospital partner that really can work with us to develop programs, but also help us be successful in a lot of our risk contracts. a lot of healthcare is moving away from fee-for-service to risk contracts. And we have 4 or 5 organizations that we have risk contracts with. It's invisible to patients. They doesn't affect their choices, it doesn't affect their care. But we have agreed with the insurers that we're going to try to be very thoughtful about the costs of care. I think how that affects average patients are that we will be able to minimize the cost growth of premiums. And I think premiums have continued to increase across the country, and it's affecting people's ability to really live the rest of their life. It affects their ability to, buy a bigger house or send their kids to college. It's become a bigger and bigger component of the average paycheck. So, we're kind of all responsible to figure out how we can deliver healthcare a little bit more effectively, a little less expensively, to all the people we serve.
Yeah, that makes sense. And that's a challenge for healthcare organizations across the country. It's not just us. I mean, there's a lot of pressure in the healthcare environment. And so from your experience in Massachusetts, Dr. Conroy came to us from Leahy Clinic. Is there anything that you can share with us just about the pressures in the healthcare system in general?
So I would say that in Massachusetts, how insurance was really structured is very, very different. There was a lot of tiering and steering. That was part of the benefit design, which is the product your insurance company sells you, trying to keep people in narrow networks in Massachusetts. In New Hampshire, there's a lot more focus on high deductible plans.
Right.
So people have $1,500, $3,000, $5,000 deductibles. I would say we need to take a lot of that information and better understand the behavioral economics around that. Do people avoid appropriate visits with their primary care provider because all of that is out of pocket? Are people actually not doing the things we would regard as good care, number one? And then number two, when we look at their longitudinal spend, are they really saving money? I think that will help us actually do a better job designing better benefits. And it's an opportunity for us to take the information we have at Dartmouth-Hitchcock and work with TDI and actually talk about the impact of that. We do have the data, and that could inform not only the people in the state, but probably could inform people nationally. The second thing is Massachusetts is very unique in the concentration of teaching hospitals in Massachusetts versus the rest of the country. New Hampshire is more like the rest of the country, where you have one academic medical center, you have a number of tertiary care facilities, and a lot of community hospitals, and then probably many more critical access hospitals. I think the costs of delivering care in those settings are very different. Teaching hospitals are about 30% more expensive than your average community hospital. And that has to do with many other variables that are really associated with doing research, educating, future physicians and nurses for the workforce. All of that costs a little bit more money. Again, that's invisible to the patient because their benefit design doesn't usually discriminate from that. But it is visible when you actually look at the total costs across a state or a region. And the costs of care, healthcare costs in Massachusetts is higher than other areas of the country. And some of that has to do with just the volume of care that's delivered at teaching hospitals.
That makes sense.
Yeah.
Great. Well, I have a lighter bit of a question for you. So I read in the newspaper article about you that you used to be a waitress when you were at Dartmouth College. So Dr. Conroy, who is now our new CEO and president of Dartmouth-Hitchcock, actually went to school here at Dartmouth College as an undergrad studying chemistry. So the question is, how are your waitressing skills now? Just kidding, smiley face. But seriously, what do you do in your spare time now that you're here in the Upper Valley?
So yes, I was a waitress at Peter Christian's, and for any of you that actually were here years ago, Peter Christian's was the place to go, I think, in Hanover. We used to have lines outside the door Friday and Saturday, almost all day, people waiting to get in there. There are a lot of important things to learn from waitressing, bartending, working in the food service industry. I think you get a real appreciation of service.
Sure.
And you get an understanding of how to deal with customers that may be happy and may be unhappy, and how to really manage that. A lot of those skills and experiences are transferable to healthcare.
Oh, interesting.
When you think about it, healthcare is a service industry.
Sure.
We are taking care of people, and we are taking care of their families. And when they're unhappy, just if you were waitressing and you had a table that was really unhappy, you would not just walk away.
Right.
You try to figure out how to fix the things that are making them unhappy. And because return business is really important, that translates to healthcare. If you have a family member or a patient that's unhappy because things are taking too long or they don't feel like they understand the process, we have to try to solve that for them, because every patient that has a great experience is going to tell 2 or 3 people. But anybody that has a negative experience is going to tell 7 or 8 people.
Right.
And we actually depend on return business, just like a restaurant. In fact, if I could keep all of my return business, I would not have to advertise at all.
Right.
Because we have more business than we can take care of. So I think they're really important skills to use. I think there are a lot of team building skills. You've got to work with a busboy, and you've got to work with the cook in the kitchen, and you've got to work with the rest of the wait staff, and you have to help each other out. And so there are a lot of team building skills that you learn in that type of industry. So, people that are only concerned about themselves rarely make a lot of money in the restaurant industry. So,
Right. So it's good training ground for
Yeah.
your career as a doctor and then a CEO.
yeah. And I love to cook. I was also the cook there for at least 2 years of my 3 years there.
Oh, at the college.
At Dartmouth, at Peter Christian's.
Oh, at Peter Christian's.
Yeah, so it was good.
Oh,
I
wow.
still, I think that people actually like to sit next to me in some of my morning classes because I still smelled a little bit like mustard sauce, and that they kind of like that smell.
Oh.
And it was a great experience, and I now continue to cook. That's the one kind of creative thing that I can do all the time.
What's your favorite thing to cook?
So, all right, don't listen to any cardiologists. So I'm making an incredible steak. I do the steak with the hot cast iron pan, searing it on both sides, and then you putting it in a 400-degree oven for 6 minutes with a pat of butter on the top of it. So it just gets nice and rich and greasy. But other things that I make, I make my own pasta often, and I do.
Really, from scratch?
Yeah, it's actually very easy.
Oh.
Yeah, and I do a great fettuccine carbonara. Another one that's not for the heart smart.
That's great.
But anyway, it's I love cooking.
That's great.
Yeah.
Well, we do have a question that came in. So again, if you want to submit a question for Dr. Conroy, just type it into the comments section. We are monitoring those. So what does DHMC do to promote diverse hiring of staff and maintain an inclusive environment for employees?
I have received a number of emails from some internal teams that are working on several issues. Number one, how do we actually educate people about racial bias and how that affects both our interactions with patients and our interactions with the community. We have a growing number of African American citizens in the Upper Valley, and it's a shift in the demographics when the Upper Valley used to be essentially Caucasian, and sometimes they find it difficult, number one, to access care, and number two, some of them have said that there are certain diseases that are really different for African Americans, and they're not sure that we have it on our radar screen as prominently as we should, number one. Number two, we have a diverse staff here from a trainee and a medical student perspective. But again, a lot of our staff reflects the community in the Upper Valley that we hire into, and that creates some conflicts for us. Our medical students and our residents have said, you know, we don't have the diverse mentors that we need within the teaching staff. You know, people want to see themselves in the people that they're learning from, and you know, we need to kind of have a whole different shift on how we kind of recruit and hire leaders across the organization here, so people that we train can actually see themselves in those leaders. I think that you know, just by being more diverse, we're just going to be better. We push that from a female perspective for a long time, but you know, over 50% of the women, or the people going to medical school, are women now, so we're slowly changing that. But gender is not the only diversity that you bring to the table. It's racial, it's cultural, etc. And it just makes us better as an organization.
That's a great answer. So just a reminder for those who have just logged on, we are here today with Dr. Joanne Conroy, our new CEO of Dartmouth-Hitchcock. And if you have any questions, please feel free to just type them into the comments section. We are monitoring. And if you're watching on playback, please feel free to ask a question anyway, because we'll monitor after this session is over. So we do have another question that came in. So given the scale of the opioid epidemic in New Hampshire, what are your plans for Dartmouth-Hitchcock as a national example in tackling this problem?
So there are a couple ways I think we need to approach it. We do have a number of teams that are working on specific programs around addicted moms, specific programs around educating kids in elementary school and middle school about the signs of somebody that may be depressed or maybe not connecting with the community and are at risk for experimentation. We do have a number of programs that are focused on integrating behavioral health into primary care, because we do know that the connection between substance abuse and behavioral health issues is actually quite high. And how do we identify people ahead of time? What we need to do, though, is take those observations and those small pilots and try to get scale across our community. So Sally Kraft, in her population health, is starting to take discoveries or things that we know work and then try to see how we can implement them across the populations that we actually gather a lot of data on and we're accountable and responsible for. So one of those is our own patient population, but the second one is the population within our accountable care organization, and we're at full risk for those Medicare patients in that organization. And Medicare patients have the same challenges we do. The opioid crisis is not just a crisis for young people. In fact, substance abuse in elders is actually much higher than most people would think. Yeah, especially when they face issues related to loneliness and isolation. They have challenges with that. We have a large high-risk population that we care for in our outpatient clinics. And I think then the communities we serve, so we're accountable to those communities. And then really New Hampshire and Vermont, what are we doing at a state level to really help bring groups together and talk about this? So I think we have to lead by example and demonstrate that you can implement these programs across certain groups, and then work with other interested communities to help them do that. This is not something that one organization can attack alone. It's something that you need really the collective impact from many community organizations that are all committed to the same outcome.
Sure. Now you have an interesting perspective about the crisis as an anesthesiologist. I've heard you talk about that a little bit. Do you want to share those observations?
Yeah. So I'm an anesthesiologist. I finished my training in 1986, and I was one of the first kind of wave of people to actually become board certified in pain management. When I was training and in the early part of my practice, there was an ongoing conversation about how do we manage chronic pain and the use of narcotics in chronic pain on a long-term basis. There are anesthesiologists use a lot of narcotics in the operating room. I put them in two easy categories. There are ones that are natural, which maybe they have kind of natural active ingredients, and Demerol and morphine are two of those. And then there are those that are synthetic, and it's fentanyl, sufentanil, alfentanil. And then people hear the names carfentanil, which is a modification of that that's used as an animal tranquilizer. They have incredible euphoria associated with these synthetic narcotics. Less euphoria from Demerol and morphine. Mm-hmm. The thing is, when we were starting to roll out more and more synthetic narcotics, some of the pharmaceutical companies were developing synthetic narcotics that were incredibly potent and had even more euphoria than the ones that we currently use. And anesthesiologists as a group just said, stop this. Right. We actually don't need anything that's more powerful, and we certainly don't need anything that causes more euphoria. And I have to say, the pharmaceutical companies realized that that market was not going to be one that they wanted to get into. So there were many drugs that we developed that probably are no longer commercially available, simply because of that. But I think people don't appreciate the side effects of some of these narcotics drive a lot of the addiction. Right. I had a resident that was addicted to sufentanil, which shocked me because it was incredibly potent and caused respiratory arrest. We use it for cardiac cases. But he honestly told me he failed in his recovery and had to leave anesthesia. But he said, honestly, the euphoria that he had after that one experience, he never forgot. And
after just one experience.
Yeah, he never forgot it. And he said he needed to leave anesthesia because he would spend the rest of his life trying to figuring out how to create that again. So I think we don't really appreciate what these drugs do centrally in terms of neurotransmitters for a lot of the people that are incredibly affected by them. So
yeah, it's a very tough situation that not only our state faces, but the whole country.
The whole country.
Yeah. So those of you who may have just logged on, we are here with Dr. Joanne Conroy, our new CEO and President of Dartmouth-Hitchcock. So she's happy to answer any questions that you might have, so just type them into the comments section. So we do have another one that came in, a little bit on the lighter side. As a Dartmouth grad, what's been your favorite thing about reconnecting to this area?
So some things have changed, but a lot of things have remained the same.
No more Peter Christians, right?
No more Peter Christians. The one in New London, I think they started to try to restore the building, and now they demolished it, and I think they're going to rebuild it. But it is, Main Street still feels the same. The college, although it has more buildings, still has that sense of a really gorgeous college town. I've actually gotten in my car and driven on some of the back roads of New Hampshire, Vermont, and many of the places that I used to visit 30 years ago still have the same small town feel. It's just beautiful when you drive through Vermont and New Hampshire and just kind of the rolling hills and just the pastoral kind of beauty of the area is really incredible. There's some things that have changed though. White River Junction is kind of an up-and-coming kind of spot for restaurants and music, and that's kind of great to see some of these smaller towns actually develop a new identity. And what was fascinating too is how far people drive now. That we have a number of our providers and employees that actually live in Eastman and Grantham and drive 20 minutes. That community has totally shifted over the few years. It used to be just a retirement or second home community, and now it is actually really a bedroom community of the expanding industry that we see here in Hanover. So it's actually just great to kind of drive around.
That's great. Must be nice to just come back, a little family reunion in a way, or a school reunion, just reconnecting in that way.
It is. It is. It is.
So for those of you who may have just joined us, we are here with Dr. Joanne Conroy, our new CEO and President of Dartmouth-Hitchcock. If you have any questions, just type them into the comments section. So we have another one that's, I think we may need to explain the question a little bit. So what's your voluntary turnover for the last quarter and year? And we may need to connect with our HR department on this, but I think they're referring to our employee turnover.
So it depends on the cohort, and we actually follow it closely. Our nursing turnover is actually quite high. Mm-hmm. It is, I think it's above 13%, which I believe is actually quite high for this area. And currently we have close to 100 travelers that are here working. Because
and travelers are people who are sent in from other places.
Right, they're nurses that we hire that come here for sometimes a month, sometimes 12 weeks, because we have a difficult time recruiting nurses. You know, there is a nursing shortage nationally, and we are talking about how we can get actually really creative in recruiting nurses, and not just nurses, but it affects a lot of our really technical subspecialties across the institution. When we look at our physician turnover, we follow that. We look at it within primary care and specialty areas. It's actually quite low, but that doesn't mean we don't attend to the issues that affect our providers throughout the organization. I don't take it for granted that just because people are here and they've moved their families here, that they're not going to look at other opportunities if we don't meet their kind of personal and professional kind of desires for development and growth. So, but we do actually track that very, very closely. It's a voluntary turnover is kind of a metric of, how satisfied are people with the working environment.
So that goes back to the engagement survey.
Yeah. I don't think people move from here for money. It's something else we're not doing, and we have to really think about that.
Right, that makes sense. Yeah. Another question that came in advance is, I understand that you go down to the cafeteria almost every day for lunch and invite yourself to sit with employees. What kind of advice do they give you when you're sitting with them?
Yeah, great advice. Often they say communicate. They say sometimes we don't understand what's going on, and they'd like to hear about things before they read them in the newspaper. Sure. I think that's a really reasonable request for employees. Some other comments have been about being visible, which, the cafeteria is just one example of that, but our whole senior team is focusing on where do we want to be predictably visible so employees know to reach out to us. And a rounding schedule. I know that Dan Jansen goes off-site where all of his financial team work, and he spends Fridays with his team off-site because he wants to be kind of visible to them. I know that Ed Marins has a lot of responsibilities across the health system, so he's on the road usually at least one night a week, actually going to medical staff meetings and board meetings across the organization. We are trying to round off shift as well. We've talked about coming in and having a night council and actually being here for people that are working the 7P to 7A shift. There's a lot that happens in an institution like this after 7 p.m. It's a very different culture. It's a different pace, and people have different issues that they want to bring forward to us. So we want to kind of create a forum so people feel free to identify a problem and maybe come forward with a solution. Some people have said, don't fire housekeepers if you don't fire the same number of VPs. I kind of get that. I understand that, and I think that how transparent can you be about why you decide to right size certain parts of the organization. We are trying to make the senior team kind of lean, very kind of traditional paths of accountability, push as much as we can in terms of decision making down to the VP level, then have them push that down to their manager level, and actually push it down to the frontline level, because they do know where the problems are, and being empowered is a big part of being engaged.
Sure.
How can you allow people autonomously to feel that they can identify a problem and solve it in their work area?
Right, that makes sense. So for those of you who just joined us, we are here with Dr. Joanne Conroy, our CEO and President of Dartmouth-Hitchcock. If you would like to ask a question, just type it into the comments section. If you're watching this on playback, please feel free to also type in a question, because we'll make sure that Dr. Conroy sees those and is able to get back to you. Speaking of which, so you are a Facebook user. Are you a Twitter user as well?
I am. I use Twitter a little bit, yes, but I am a Facebook user. My 93-year-old mom is also on Facebook.
Oh, really?
Yeah, so I got her an iPad, and one piece of feedback I would give to Apple stores is my mom is really hard of hearing. She lives independently. She's 93 years old, lives in Aiken, South Carolina. She still drives.
Oh.
She's actually a pretty good driver. But when she goes into the Apple store, if you wear a hearing aid, because of the hard surfaces and everything is kind of metallic, it's very, very hard for somebody that's hearing impaired to actually understand what's going on in the Apple store. So we do a lot of long distance coaching on keeping her iPad connected and up to date. But she does get on Facebook and likes to see the pictures and kind of communicate with the rest of the family. I have a whole group of friends that I have on Facebook. Again, it's really just sharing pictures and supporting each other. So yeah, it's something I don't usually use for my business, although I do like a lot of the Dartmouth-Hitchcock Facebook pages, and but it's kind of a really great way to communicate with a lot of the people that you're really close to.
That's great. Well, and you mentioned that people that you've been meeting in the cafeteria who've been advising you or asking you questions, they've said that they want you to communicate, and that's important for you as well. Yeah. So we just started Joanne's Journal. Yes. Do you want to talk a little bit about that and some of the other communication things that you have in mind?
Yeah. So I think communication is really important, and authentic communication. So your team has been great, Victoria, to help establish Joanne's Journal, which is a weekly message for me. I write my own message. Thank you, Victoria, for expertly editing it. But I write my own message to really talk about the things that I think are important throughout the organization. And then there are some other messages with links to pictures and feedback on things that are going on in the organization. Employees is part of the sense of belonging. I want people to read my message, but they also want to see what's going on across the organization, and that's usually accompanied by some pictures and some kind of funny stories about what people are doing. That creates that sense of community, and I think that's a really important way to communicate. Other ways of communicating are just walking around and reinforcing that. Town halls, answering questions. Communication, you have to have multiple vehicles of communicating, and then you need to make sure that you continue to kind of send the same message throughout those. We also have a CEO mailbox where we get a lot of emails from people, and that's just a best practice in the industry to really try to be really accessible and also accountable. I've always told young leaders as they move up in the organization that, as you become a leader, you become accountable to more people, not accountable to fewer. And that's an important lesson for leaders to know.
So that's great advice. And hopefully we can use Facebook Live as another communications venue. If we get a good viewership here, maybe we'll continue this on maybe once every 2 months if you're willing.
Great. Yep. Happy to.
Okay.
Happy
great.
to.
All right. Well, thank you for your time today. We appreciate it.
Thank you
to our Facebook viewers, either live or in the future. We understand there were a couple of audio problems, so we apologize for that, but thank you for being with us today.